Hi everybody, welcome to our module on pulmonary physiology. So there's a bunch of smaller topics that all fall under the subject heading of pulmonary physiology, and we'll go through them all in this module. You need to know, especially for step 1, about lung volumes and capacities, about ventilation and dead space, about lung and chest wall pressures, and then finally we'll talk about the compliance of the lungs and a little bit about airflow resistance. So let's start by talking about lung volumes. And the first thing to know about lung volumes is the average person can only inhale about 6 liters of air. That's the most you can fill your lungs on average. You also should know that no matter how hard you try to push the air out of your lungs, you will never be able to get the volume down below about a liter or so. That air that's always left inside your lungs, no matter how hard you push out, is called the residual volume. Now, when you're not thinking about breathing and you're not trying to inhale deeply or exhale vigorously, that's called quiet breathing. And when you're breathing quietly, your lungs are inhaling air such that they go from about 2.5 liters up to about 3 liters and then back to about 2.5 liters. And this amount of air that's going in and out with each quiet breath is called the tidal volume. That's the amount of air that goes in and out with quiet breathing. Now, if you try to inhale as deeply as you can, you will fill your lungs all the way up to their maximum capacity, that 6 liters amount. That's called the total lung capacity. And that extra volume of air that you drew in above your tidal volume is called the inspiratory reserve volume. That's the amount you can inspire if you try really hard, the extra air beyond the tidal volume. Additionally, if you exhale as hard as you can and push out as much air as possible, you will put out an extra volume of air beyond the tidal volume, and that extra volume of air is called the expiratory reserve volume. And then a final number that I want to mention here is the amount of air that's inside the lungs at the end of a quiet breath, which is shown right here in this picture. That's called the functional residual capacity, and that's a very important volume because that's where the lungs come to rest at the end of a quiet breath. And we'll talk later about how the fact that the FRC is where the forces inside the lungs are balanced, and that's why you end up there at the end of a quiet breath. So I mentioned a lot of things in that picture, so let's review them because they're important. There are 4 volumes that you need to know. The first is the tidal volume. This is the air that goes in and out with each quiet breath. The next is the expiratory reserve volume. This is extra air that can be pushed out with force beyond the tidal volume. And after you push out that expiratory reserve volume, all that remains in the lungs is the residual volume. Then there's the inspiratory reserve volume. This is extra air that can be drawn in with force beyond the tidal volume. And when you inhale the inspiratory reserve volume, the lungs will be filled to capacity. And then finally, there's that residual volume, that air that can't be blown out no matter how hard you try. In addition to the 4 volumes, there are 4 capacities that you need to know, and a capacity is a sum of at least 2 volumes. So the first one is the total lung capacity. This is a sum of all the volumes in the lung, the residual volume, the expiratory reserve volume, the inspiratory reserve, and the tidal volume. The next one is the inspiratory capacity. This is the most air you can inspire. So it's the tidal volume, which is what you inspire with a quiet breath, plus the inspiratory reserve volume, which is that extra volume you can inspire with force. And then the third capacity is the vital capacity. This is the most you can exhale. So this is the tidal volume, plus the inspiratory reserve volume, plus the expiratory reserve volume. This is everything but the residual volume, which is that little bit of air that you just can't get out of the lungs no matter how hard you try. And then the fourth capacity you need to know is that important functional residual capacity. This is the residual volume after a quiet expiration. It's equal to the residual volume plus the expiratory reserve volume. It's the volume when the system is relaxed, and that means that the chest wall force pulling out equals the lung force pulling in. And this is going to be important later when we talk about these 2 forces and how they balance to determine the FRC. So I'll give you a trick I use to remember the volumes. I just remember them in this order: RV first, then ERV, then IRV, then TV. And if you remember them in this order, then the bottom 2 are the inspiratory capacity. The bottom 3 are the vital capacity. The top 2 are the FRC. And then finally, all 4 of them together are the total lung capacity. I don't know if that helps you, but that's how I've always kept them straight. So the next pulmonary physiology topic we're going to discuss is ventilation. So ventilation equals the volume of air you breathe times the frequency of breathing, which is the respiratory rate. So for example, if you took in 500 cc's of air per breath times 20 breaths per minute, that would be a ventilation rate of 10,000 cc's per minute, or 10 liters per minute. Now there are 2 places that all that ventilated air goes. The first place is to the alveoli, and alveolar ventilation is very useful for gas exchange because the alveoli are where red blood cells can pick up oxygen. However, some of that air goes to what's called dead space, and this is ventilation to areas where gas exchange can't occur. It's wasted ventilation. So air that goes to the nose and the trachea and other areas with no gas exchange is called dead space ventilation. So let's talk about dead space in a little more detail. As I said before, it's space filled with air, but no gas exchange is occurring. There are two subtypes of dead space. The first is called anatomic dead space, and these are anatomic structures where gas exchange can't occur. And it's basically the conducting portions of the respiratory tract, so it's things like the nose and the trachea. The second type of dead space is called physiologic dead space. This is the anatomic dead space plus volume of alveoli that don't exchange gas. It turns out that not every single alveolus works just right to exchange gas, so some air goes to alveoli but doesn't get used. This is because of insufficient perfusion of blood usually. The apex is the largest contributor because it has less blood than the base. So physiologic dead space is all that space that doesn't participate in gas exchange. It includes the anatomic dead space, but also alveoli that don't work very well. And you should know that physiologic dead space is what increases in many diseases. When the lungs become sick, this isn't going to increase the size of your nose or trachea. The anatomic dead space is not going to change, but those alveoli that don't exchange gas are going to go up, and that means that the physiologic dead space is going to increase. There is a method for measuring dead space. It's not often done. It's an experimental method, and it will determine the physiologic dead space. It's called Bohr's method, and it's an equation that gives you the dead space from three numbers. So first you need the tidal volume. This is how much air goes in and out with each breath. So you have to hook the patient up to a machine and measure the volume of air going in and out with each breath. You also need to measure the amount of carbon dioxide in the air that the patient is exhaling with each breath. And then finally, you need to do an arterial blood gas and determine the CO2 concentration in the artery. Once you know those numbers, you plug it into this equation down here, which says the ratio of dead space, and remember this is physiologic dead space, not anatomic, it's physiologic. The ratio of physiologic dead space to tidal volume is equal to the arterial CO2 concentration minus the expired over the arterial. And this is sometimes done in different disease states to determine if the physiologic dead space has gone up or stayed normal. Okay, now let's review some basic principles about how we describe air pressure inside and outside of the lungs and about how air pressure creates air movement. So first of all, you should know that outside of our body, the pressure is equal to atmospheric pressure, which is 760 millimeters of mercury. However, by convention, we often describe this pressure as 0 millimeters of mercury, meaning that there is 0 millimeters of difference between the pressure and the atmospheric pressure. So anytime you see a pressure denoted as 0 millimeters of mercury, what they are trying to tell you is that the pressure is no different than atmospheric pressure. Now, if you think about your lungs, at the end of inspiration, before you begin exhaling, there is no movement of air because you have completed inhaling a breath of air. At this point in time, the pressure in the alveoli is equal to atmospheric pressure. In other words, it's 760 or 0. And you know it must be equal to atmospheric because there's no air movement at the end of inspiration. Whenever there is no difference in pressure between outside the lungs and inside the alveoli, there will be no flow of air. When you begin to exhale, what happens is that the pressure inside the alveoli become positive, and we'll talk about why this occurs in a minute. But just so you understand the basic principles, let's assume that the pressure goes up to 765 millimeters of mercury, or plus 5. This will create a difference of plus 5 between the alveoli and outside the body, and that will drive airflow out of the body. When you take in a breath of air, the pressure in the alveoli becomes negative. In other words, it becomes somewhat lower than atmospheric pressure. Let's say it's 755 or minus 5. This creates a direction for airflow into the lungs, and therefore air will flow into our lungs. So these are just some basic principles of how we describe pressure and how pressure determines airflow. So now that you understand that, we can talk about the structures that create those positive and negative pressures inside our alveoli, and that is the lung and chest walls. Now, in order to understand how our lung and chest walls work together to modify the pressures in our alveoli and create movement of air, you have to understand two basic principles. The first one is that the lung's general tendency is to collapse. Your lungs, if left to their own devices, want to collapse and pull inward and recoil. You can think of your lungs like a balloon, and if a balloon has no forces pushing out on the walls, it will collapse into a crumpled ball on the floor. That's how you can think of your lungs. Your chest wall, on the other hand, likes to expand. If left to its own devices, the chest wall has all those muscles, and they like to push out to the sides and expand, and therefore your lungs prefer to sit relatively stretched far apart with some volume of air in between them. In other words, your lungs like to spring outward. And these two principles here are very important in order to understand how the lung and chest walls work together to create air movement. So let's drill down on this a little further, and let's begin by talking about the lung first. So the relationship between volume and pressure in the lungs looks like what I've drawn on the screen here. So if you put no pressure into our lungs, in other words, if there's no air pressure filling the alveoli, the lungs will tend to have no volume. Like I described in the last slide, they will collapse like that crumpled balloon on the floor. If you begin to apply pressure to the walls of the lung, they will start to increase in size. In other words, they will begin to expand in terms of their volume up to a maximum point, beyond which it gets very hard to expand them even further. In other words, even if you add lots and lots of pressure, you don't get much volume once you get out to a certain point. And this is the pressure-volume relationship of the lungs. The chest wall, on the other hand, has a pressure-volume relationship that looks like what I've shown on the screen here. If you apply no pressure to the walls of the chest, it will still have a volume way up here. That's because of what I told you earlier. The chest wall likes to spring apart and hold a volume of air even at rest when no forces are being applied to the walls. Now, if you apply positive pressure, you can increase the volume of air that is held within the chest walls. And if you apply negative pressure, if you go down this direction on the x-axis, you can withdraw volume from within the chest walls. But the point here is that at rest, the chest walls like to have a volume because they naturally spring apart and hold a volume of air even when no forces are being applied to the walls. Now, if you think about air that's inside of the alveoli in our lungs, that air is surrounded by both lung tissue and the chest wall. Therefore, it is the combination of the chest wall and the lung forces that determine the pressure-volume relationship of the air in our alveoli, and that's what's shown on this green curve here. This is the pressure-volume relationship of the entire respiratory system. In other words, the pressure-volume relationship of air molecules sitting within an alveoli surrounded by both the lungs and the chest wall. They have a pressure-volume relationship that is a combination of the blue and red lines shown on the screen here. And if you look down at the bottom of the screen, there's a very important pressure here of 0. Remember what I told you earlier. When the pressure inside the alveoli is 0, that means there's no air movement. And at 0, the volume inside the respiratory system as a whole is this volume right here. And that is the very important volume, the functional residual capacity. At this volume right here, the tendency of the lungs to collapse and move the system this way is balanced by the tendency of the chest wall to expand and move the system this way. The forces are balanced. That's why there is no pressure on the air molecules inside the alveoli. And that volume that occurs at that point is the FRC. So I've summarized some of these points on this slide because they're important. So the functional residual capacity is the volume at which point the lungs' tendency to collapse inward is balanced by the chest wall's tendency to pull outward. It is the volume where the lungs rest after quiet exhalation. This is the point in time when the pressure inside the system is 0. There's no positive or negative pressure from the push-pull of the lungs or chest wall, and the pressure inside the alveoli equals atmospheric pressure, and therefore, as I showed you earlier, there is no flow of air. Let me make a couple more important points about the pressures inside the lungs. When the pressure in the alveoli is 0, there will be no airflow. However, for the pressure in the alveoli to be 0, the pressure in the pleural space must be negative. Why is that the case? Well, remember I told you before that the lungs have a tendency to collapse on themselves. And if the lung tissue surrounding air in the alveoli were to collapse, it would create a positive pressure in the alveoli. Therefore, for the alveoli to have a pressure of 0 and avoid that positive pressure, there must be negative pressure in the pleural space. In other words, anytime the pressure inside the alveoli is 0, it means the positive pressure of the lung tissue collapsing on air molecules is balanced by negative pressure in the pleural space. This will make more sense once we go through this diagram on the screen here. This diagram shows alveoli and pleural pressures in the lungs during quiet tidal breathing. So when the pressures in the alveoli are 0, as I described earlier, there is no airflow. Then we begin to inhale and the pressures in the alveoli briefly become negative. This draws air into the alveoli and brings the pressure back up to 0. Then we begin to exhale and the pressure in the alveoli briefly becomes positive. This pushes air out of the alveoli and drives the pressure back to 0. So in the alveoli, the pressure is going from 0 to negative to 0 to positive over and over again. In the intrapleural space, however, during quiet breathing, the pressure is always negative. It becomes more negative when we inhale, it becomes less negative when we exhale, but the pressure is always negative in the intrapleural space during normal quiet tidal breathing. Make sure you understand this. This is often a point of confusion for students. You will read in your textbooks about the term transpulmonary pressure, so let's talk about what that means now. The transpulmonary pressure is the difference between alveolar pressure and intrapleural pressure. It is the net sum of pressure forces acting against the lung tissue. So to understand this, let's imagine that we have a pressure of +5 in the pleural space. This is exerting a force of 5 in this direction against the alveolar or lung tissue. Now let's imagine that we have a pressure of +5 inside the alveoli. That is exerting a force of +5 in this direction, pushing outward on the lung tissue. This means that the transpulmonary pressure is equal to the +5 from outside the lungs minus the +5 from inside the lungs, or 0. In other words, the two pressures cancel each other out. This is fairly easy to understand. What's confusing is that in the real lungs, the pressures are not equal inside and outside. What we have is pressures that are very negative in the pleural space, such as -30, at the same time that the pressure may be 0 in the alveoli. This is the case because, as I told you before, the lungs like to collapse in on themselves. Therefore, to keep them open, you need a negative pressure surrounding the lungs to keep them open and maintain a pressure of 0 inside the alveoli. So in a situation like what I've shown you on the screen, which is a more realistic situation where we have a pressure of 0 inside the alveoli and a pressure of -30 outside, the transpulmonary pressure in this situation is +30, and this is the case that is often found during many parts of the respiratory cycles in the lungs. And I've summarized some important points here. A positive transpulmonary pressure holds the airways open. That's like what I've shown on the screen here. If you have a negative transpulmonary pressure, that will lead to airway collapse, and that's a bad thing that we don't want. Now let's talk about a forced exhalation. This is a special circumstance in pulmonary physiology. When you forcefully drive air out of your lungs, you create a positive pressure in the pleural space. This compresses the airway and puts pressure on the alveoli and creates a positive pressure in the airway. This will push air out and make airflow out of your lungs. So remember before that I told you that pleural pressure is always negative during quiet or tidal breathing. That is not so during a forced exhalation. During a forced exhalation, you can create positive pressure in the pleural space outside of the alveoli. This will drive airflow out of the alveoli and out of the lungs. And that brings me to an important concept in pulmonary physiology, and that is the equal pressure point. When you create positive pressure in the pleural space, there will be a point at which the positive pressure surrounding the alveoli is equal to the pressure within the alveoli, and this is called the equal pressure point. It's where the pleural pressure equals the airway pressure. Beyond this point in the airways, the airway will collapse. Let me explain this. So if you look at this diagram at the bottom of the screen, let's imagine that we are exhaling forcefully and we create a pressure of +60 in the pleural space. This will generate a pressure higher than +60 inside the alveoli, for example, +90. Why is it higher? That's because the pressure inside the alveoli is equal to the pleural pressure plus the elastic recoil. Remember, the lungs want to collapse in on themselves. They generate pressure on the molecules inside the alveoli. Therefore, we don't get the same pressure inside the alveoli as the pleural space. We don't get +60. We get something higher because we are adding to that +60 the pressure of elastic recoil. Now, as air flows down the alveolus, there will be resistance to flow and the pressure will slowly drop. At some point, it could become +75, and then at some point in the lungs, it will become +60. This is the equal pressure point. The pressure in the pleural space of +60 is equal to the pressure inside the airways. Beyond this point, the pressure in the airways is going to be less than 60, and therefore there is going to be a tendency for the airways to collapse. Now, the good news is that if your lungs are healthy, the equal pressure point occurs in the cartilaginous airways. These are airways that are stiff, and the cartilage prevents the airway from collapsing. In disease states, however, the equal pressure point can move distally in the lungs toward the alveoli. In other words, instead of being in the cartilaginous airways, the equal pressure point may occur in areas where the walls are thin, like in the bronchioles, and this can lead to airway collapse. For example, patients who have obstruction to airflow, like from bronchitis, have more pressure drop as air flows out of their lungs. So instead of this point of +60 being reached here, it might be reached here because there's a greater pressure drop as air flows out of the lungs. Or patients could have emphysema. When patients have emphysema, there's loss of elastic recoil. So when we generate +60 out here in the pleural space, instead of +90 in the alveoli, maybe we only get +70. That will cause the equal pressure point to also occur more distally in the airways closer to the alveoli. And as I said before, it can occur such that the equal pressure point happens in the thin-walled bronchioles. This will result in collapse, obstruction to airflow, and air trapping, and this is an important element of the pathophysiology of obstructive airway disease. Next pulmonary physiology topic we're going to discuss is lung compliance, and compliance basically means stiffness of the lungs. It's very similar in many ways to ventricular compliance in the heart. Compliance means for a given pressure change how much volume changes. In fact, you can calculate the compliance of any structure if you apply a certain pressure change that generates a certain volume change, and the ratio of the volume change to the pressure change is the compliance. We don't usually measure it for the lungs, so we don't usually talk about numbers. So that you have a picture in your head, let's talk about what a compliant lung would look like. So this is a lung that's very easily relaxed. It's very easy to stretch. So for a small amount of diaphragm effort, you would generate a small pressure change across the lungs, and this would give you a large volume change. Compliant lungs are lungs where it's easy to move the air in and out. It's easy to stretch them and fill them with air. Contrast that with a non-compliant lung. In this case, you would give a large amount of diaphragm effort to create a big pressure change across the lung, but this would only give you a small change in volume because the lungs are stiff. In non-compliant lungs, it's very hard to move the air in and out. So this is how normal and non-compliant lungs look on a graph. So down here at the bottom, we've got the pressure. So as you give a given pressure change, say you go from 0 to 20, for the normal lung, you go all the way up here to some high volume right here, but the non-compliant lung, you get a much smaller change in volume because that lung is less stretchable and more stiff. So what are some conditions that increase or decrease lung compliance? Well, anytime you get an infiltrate inside the lungs, like pneumonia, that's going to make the lungs stiff. It's hard to stretch them when they're full of bugs and inflammatory tissue. Pulmonary edema, which is wetness around the lungs, can make the lungs stiff. And then if you have fibrous tissue in the lungs, they will become stiff. So all these conditions have decreased lung compliance. You get increased lung compliance in emphysema. So in emphysema, you get destruction of the alveoli and the lungs become very floppy and their compliance goes up. And then also it's normal to have a little bit of increase in lung compliance with aging. The final pulmonary physiology topic I'll discuss is resistance to airflow. So the boards like to correlate physics and flow mechanics to physiology. And one way to do that is to talk about resistance to flow in the air vessels. So the first thing to know is that the upper airways comprise about 50% of the resistance to airflow. So these are structures like the nose, the mouth, and the pharynx. The lower airways comprise the rest of the resistance, and as the vessels branch and get smaller, the highest resistance to flow comes at the medium bronchi level. And that's because at this branch point, there's a lot of turbulent flow, and that creates resistance. The lowest resistance to airflow is in the terminal bronchioles. This allows for very slow laminar flow in the terminal bronchioles, which is good for transmission of air and gas exchange. So if you create a graph of air vessel size going from biggest down to smallest here, and resistance going from low to high here, you get a curve that looks like this. And the peak right here is where you've got the medium bronchi, and the low point way down here is in the terminal bronchioles. And this is sort of a classic physiology curve that's worth knowing for your boards. And that concludes our module on pulmonary physiology.